In this lecture, we're going to look at the nerve lesions of the upper limb. So we're going to have an initial overview of the nerve supply to the upper limb and then look at some typical location of the lesions and how this leads to motor and sensory deficits. We're going to look at some nerves that we've already covered in the course, so the musculocutaneous, the median and the ulnar nerves, and the radial, auxiliary and long thoracic nerves. So here we can see just on the screen on this right-hand side, we can see that we have the overview of the brachial plexus and the three cords coming away from the brachial plexus, the medial, posterior and lateral cord. How the medial and the lateral cord give rise to the musculocutaneous, the median and the ulnar nerves, and how the posterior cord gives rise to the radial and the auxiliary nerve. So we're going to look at those specific nerves and how damage to those nerves can lead to sensory and motor deficits. It's important to appreciate that coming off the brachial plexus, we have a whole series of cutaneous nerves that come either from the brachial plexus itself or come from one of those 5 terminal branches, and they supply the skin of the upper limb, as we spoke about in one of the first lectures. We can see here various regions of the upper limb and how they are supplied by various nerves. So let's start by looking at the musculocutaneous nerve. Remember, the musculocutaneous nerve, as we can see on the screen here, is involved in supplying muscles within the anterior compartment of the arm. So damage to the musculocutaneous nerve, which can happen as a penetrating injury within the axilla, maybe during a fight perhaps, damage to the musculocutaneous nerve can lead to paralysis of the muscles it supplies. So remember, it supplies coracobrachialis, it supplies biceps brachii, and it supplies brachialis. And if the musculocutaneous nerve is damaged, then therefore these muscles are not going to have that innervation, so they will become paralyzed. The effect of that is, well, if you appreciate the effect of these muscles contracting on the elbow joint and on the radio-ulnar joints, then you can appreciate that damage to the musculocutaneous nerve will lead to weakened flexion at the elbow and also weakened supination of the forearm. So damage to the musculocutaneous nerve can lead to a weakening of the elbow flexion and a weakening of supination. Sensory loss, well, if you look at damage to the musculocutaneous nerve, then via the lateral cutaneous nerve of the forearm, you have sensory loss over the lateral arm. And we can see here in this region, the musculocutaneous nerve gives rise to the lateral cutaneous nerve of the forearm. So you may well have sensory loss on this region of the forearm. This nerve that we can see running along here, the lateral cutaneous nerve of the forearm, is originating from the musculocutaneous nerve. So damage here would lead to loss of sensation. Now let's turn to the median nerve. Now there's a number of places the median nerve can be damaged. It can be damaged in the arm, at the elbow, and at the carpal tunnel. Remember, the median nerve doesn't supply anything in the arm, but it supplies a considerable amount of muscles in the anterior compartment of the forearm and in the hand. So damage to the nerve, to the median nerve, again via maybe traumatic injury to the median nerve, principally at the elbow joint is a common place, but again you can have damage up in the arm or down, as we'll see, in the wrist region. But damage at the elbow can lead to paralysis of FDS, flexor digitorum superficialis, and the medial 2 tendons of flexor digitorum profundus. So these muscles will be paralyzed. You'll also have paralysis of the thenar muscles working on the thumb and lumbricals 1 and 2, those laterally positioned lumbricals. The effect, well, again, if you appreciate what these muscles do, then the effect of damage to the median nerve is going to be an inability to flex the proximal interphalangeal joints of digits 1 to 3 and weakened flexion of digits 4 and 5. You're also going to have an inability to flex the distal interphalangeal joints of digits 2 and 3. So you can see paralysis of the median nerve leads to quite some substantial inabilities of the contractile abilities of these muscles, leading to quite a significant functional deficit. You'll also be able to see that there's going to be flexion still be possible at the distal joints of digits 4 and 5 due to the flexor digitorum profundus having the ulnar innervation. So because the tendons that pass the digits 4 and 5 from flexor digitorum profundus are from the ulnar nerve, then these are going to be spared. You're also going to have inability to flex the metacarpophalangeal joints of digits 2 to 3, and due to loss of the lumbricals, you won't be able to extend the interphalangeal joints of digits 1 and 2. So this means that when a patient is asked to form a fist, digits 2 and 3 essentially remain extended. And this is what we can see here. Due to a loss of the flexor digitorum profundus and the flexor digitorum superficialis and the various other muscles I've mentioned, like the lumbricals, because these are effectively paralyzed, that when someone is asked to form a fist, then the function of the flexor digitorum profundus that is supplied by the ulnar nerve is still intact. These digits can flex, but the remaining digits remain extended. And this is known as hand of benediction. And we can see that here on the picture. We can see digits 4 and 5 have flexed, but digits 2 and 3 remain extended. And this is indicative of median nerve damage. If the median nerve was damaged in the carpal tunnel, then you wouldn't have that problem because the median nerve would have already given off the branches to the muscles in the anterior compartment of the forearm. So the muscular branches would have already have come off here. So the function of these muscles will be preserved. However, as the nerve passes through the carpal tunnel, it can be due to carpal tunnel syndrome that you could have this problem, or if you try to lacerate, if there's a laceration of your wrists, then perhaps the median nerve could be damaged. And this could lead to paralysis of the thenar muscles and lumbricals 1 and 2. So these are supplied by the recurrent branch of the median nerve that passes through the carpal tunnel and therefore is likely to be damaged. Because of that, you have an inability to oppose the thumb, and you lose the fine motor movement that is possible via the lumbricals with digits 2 to 3. So loss of fine motor movements of the lumbricals. And we can see that here. We see the lumbricals will be damaged, and we see the thenar eminence here will be damaged due to damage to the recurrent branch of the median nerve. Sensory loss, well, you'll have tingling or reduced loss of sensation over the lateral 3.5 fingers. We can see that here. Sensory loss over fingers 1, 2, 3, and the lateral surface of finger 4 due to sensory branches from the median nerve emerging distal to the carpal tunnel. So these branches, these sensory branches coming from the median nerve that supply these fingers are coming once it's past the carpal tunnel. So they will be damaged and you'll have that tingling, reduced sensation. However, sensation of the central palm will be preserved because the branch that supplies the central palm, this palmar branch here, actually comes off the median nerve before it passes through the carpal tunnel. So because of that, it's not going to be damaged. So we can see sensory loss of the 1, 2, 3.5 fingers, but with carpal tunnel damage, the central palm sensation remains intact. Now let's move over to the ulnar nerve. The ulnar nerve passes close behind the medial epicondyle of the humerus, and then it runs again within the anterior compartment of the arm alongside the radial artery. It doesn't pass through the carpal tunnel, but it runs superficial to the flexor retinaculum in Guyon's canal, or the ulnar canal, to go and supply some muscles within the hand. But damage to the ulnar nerve, and this can be as it passes posterior to the medial epicondyle, a likely place, or compression at the elbow or Guyon's canal, can lead to damage. Sensory loss, this will be at the medial surface of the palm, the medial 1.5 fingers. Those fingers that were preserved when we had median nerve damage. So the median nerve did 3.5, The ulnar nerve is redoing the remaining 1.5 for fingers 5 and the medial surface of 4. So you'll lose sensation there. You'll also have paralysis of the vast majority of those intrinsic hand muscles. So the medial 2 lumbricals, the interossei, the hypothenar eminence muscles. These will be paralyzed with the effects on functionality. The hand will be deviated to the radial side when a fist is formed because flexor carpi ulnaris is no longer able to make a even flexion of the wrist, so the radius via the flexor carpi radialis muscles will pull it towards the radial side, so you'll have radial deviation, and you'll have an inability to flex fingers 4 and 5, and also the distal interphalangeal joints. And these are what's supplied by flexor digitorum profundus, the ulnar belly, the ulnar nerve supplying the bellies to these digits. So this time, when a patient forms a fist, digits 4 and 5 remain extended at the distal interphalangeal joint, yet the remaining fingers are flexed, and you have what's known as claw hand. If we now move on to the radial nerve passes to the posterior compartment of the arm, where it supplies triceps, and then it supplies the posterior surface of the forearm, where we can see it here. It's passing from the posterior cord, it passes the triceps muscle, which it innervates. It then runs onto the posterior surface of the forearm, supplying the extensor compartment. Damage to the radial nerve can be via a knife injury, perhaps in the axilla, or a humeral fracture where the shaft of the humerus is damaged. Paralysis, well, if the damage to the radial nerve occurs superior to the origin of the branches that supply triceps, then triceps brachii, brachioradialis, supinator, and the extensors of the wrist will all be damaged. So if the lesion is high up, say it's a humeral fracture, before it's given off the branches to triceps, then every muscle distal that it supplies will be affected. And this can have the effect of what's known as wrist drop. We can see we've got an inability to extend the wrist because the extensor muscles on the forearm are damaged. You may also have an inability to extend the forearm at the elbow joint if triceps is damaged. So you've got wrist drop primarily as the problem with a radial nerve lesion. This is due to paralysis of the extensors, and therefore you have unopposed tonic contraction of the flexor muscles, and that leads to this flexed wrist drop position. Sensory loss is going to be over the lateral aspect of the dorsal of the hand, and you can just see a small little region here which is affected by the sensory loss due to damage to the radial nerve. So let's have a look at the auxiliary nerve. Remember the auxiliary nerve passing through the quadrangular space. We can see it here, passing through the quadrangular space with the posterior circumflex humeral artery to go and supply deltoid. We can see this on the posterior view of a right shoulder. So damage to the auxiliary nerve could occur as a fracture to the surgical neck of the humerus, also due to compression of the muscles that form the quadrangular space. So if the muscles that form the quadrangular space were to become bigger, to hypertrophy, then this could compress the quadrangular space. Now, as we know, passing through the quadrangular space, as I just said, is the auxiliary nerve, then this can compress this nerve, leading to functional deficits of the deltoid. If there's a fracture to the neck of the surgical neck of the humerus, then as the auxiliary nerve passes through here, then the same problems will result. You'll have paralysis of the deltoid muscle. Paralysis leads to atrophy of the muscle, and this can lead to loss of the rounded shoulder contour as you lose the muscle mass. Now, deltoid is involved in abducting the arm, but it abducts it after the first 15 degrees. So the first part of abduction is carried out by supraspinatus, and that starts the abduction, does the first 15 degrees, and then the deltoid muscle carries on. So the individual will only be able to abduct their arm due to supraspinatus by 15 degrees. You'd also have sensory loss over a patch of skin on the lateral arm, which we can see here. This little patch of skin over the lateral aspect of the arm, shoulder region, is due to the cutaneous branches coming from the auxiliary nerve. And here we can see that they would be damaged. So you'd have loss of sensory distribution from this region. If we then look at the long thoracic nerve, the long thoracic nerve comes away from the brachial plexus and it runs down. We can pick up the long thoracic nerve here. It's running alongside serratus anterior, and it actually runs superficial to serratus anterior. Here we're looking at the right side of the thoracic cavity. This is anterior, this is posterior, this will be deltoid here, and we can just see the long thoracic nerve running down here to supply serratus anterior. So damage to the long thoracic nerve that's coming from the brachial plexus can be due to damage to the lateral thoracic wall. This can be due to a fight, or it could be due to surgery on the lateral aspect of the chest wall. If there's surgery on the breast, or if there's removal of lymph nodes in this region, then the long thoracic nerve could be damaged. The effect is that the medial border of the scapula would protrude through the skin, especially when the patient is asked to push against a fixed wall, and this is known as winged scapula. So serratus anterior is important in clamping the scapula onto the posterior chest wall. It holds the scapula onto the chest wall. So damage to the long thoracic nerve would paralyze this muscle, and therefore when you go to move your arm and you need your scapula to be anchored to make it a stable push off, then that's not going to be possible, and the scapula is then pushed into the skin, and that gives the impression of a winged scapula. The actual triangular shape of the scapula is seen as an impression on the undersurface of the skin. So in this lecture we've looked at the general nerve supply to the upper limb and some typical locations of lesions, and then looked at their motor and sensory deficits. We looked at the muscular-cutaneous nerve and that deficits with damage to this nerve. We looked at the median and ulnar nerve with hand of benediction and claw hand. We then looked at the radial nerve and wrist drop, and the auxiliary nerve, the ability for damage to this nerve to lead to failure of abduction beyond 15 degrees and the loss of shoulder contour. And then we looked at winged scapula in relation to damage to the long thoracic nerve.